Welcome to Harlow on Healthcare. I'm David Harlow, and I invite you to join me by my virtual hearth as I sit down with healthcare leaders to discuss building the future of healthcare. Today, my guest is Dr. Jay Anders, Chief Medical Officer of Medicomp Systems. Dr. Anders supports product development, serving as a representative and voice for the physician and healthcare community that Medicomp's products serve. He's previously served as Chief Medical Officer at McKesson Business Performance Services and has been instrumental in leading the first integration of Medicomp's physician documentation product into an EHR. Jay also spearheads Medicomp's Clinical Advisory Board, working closely with clinicians to ensure that company products are developed based on user needs and preferences to enhance usability. And as I understand it, Medicomp integrates clinical data through a suite of products delivering actionable, relevant information at the point of care. Jay, welcome. Thank you for joining us today.
Thank you for having me, David.
So to kick off, I wonder if you could add to what I've said and give us a thumbnail description of the suite of products that Medicomp has in the marketplace.
Medicomp has at its core a clinical intelligence engine. I mean, I call it that in particular because it's really not artificial. It's been curated over the last 40 years by experts and it contains algorithms, links, and other machine machinations to interconnect diseases with all of their associated history, physical, lab tests, states, things like that. So at its core, it's a clinical relevancy engine that mimics how the physician thinks. With that at its core, we can present at the point of care relevant elements to be documented for a particular disease, and that is any disease or combination of said diseases. We have the ability to take information from basically any source, meaning it can be text, fire services, lab data, wherever it needs to come from. Take that and put it together in a clinical organization. And what I mean by that is, if you can take, I'm an internist, so if you take one of my basic patients, they usually have 4 or 5 diseases. Charts are very thick. There's a lot of information in the record. But I want to see just their diabetes mellitus type 2 information in their medical record. Our engine has the ability to take all of their medical information and start to clinically stripe it out and present it to the provider so that they've eliminated all the clinical noise in a chart. So if I just want to see the hypertension view of a chart, a diabetes view of a chart, a kidney failure view of the chart, we have the ability to do that. We also have the ability to take disparate information, organize it into coded clinical data, and then be able to transmit that back out to whatever entity or entities need it. So I kind of call us the universal medical translator to do that.
Okay. So you're talking about sort of streamlining the data that's presented, and that of course is very useful. And I've heard a lot of descriptions of different kinds of services and products that do that. You know, when you're coming in to see specialist X after you've had a test run, there's maybe a certain subset of data that's going to be relevant for that encounter, for that specialist to see before the patient walks in the door. Mm-hmm. And I guess the issue is, how do you apply the filter? What you've alluded to is that you're applying filters based on decades of experience on behalf of the company. And I guess, are there also newer technologies that now allow you to apply that experience in a way that can streamline the output? And I guess related to that is, are we also able to streamline input, the data collection, or do we still have to go broad on the data collection side?
No, well, you can go broad if you wish. Medicomp has a coded clinical documentation system that allows the clinician to document encoded data. So it goes in already organized, and it's much easier to deal with that way. But that really doesn't hinder us at all because we have our own proprietary NLP engine that actually can take data from text and convert it into medicine terms and then act upon that as well. So to your point of do we use other things? Yes, we have an algorithm built into we call it the index, that allows us to look at all those interconnections between different data points within a medical record and produce the appropriate either filter and or documentation for that particular set of data.
Okay. And are there filters that are available sort of across the universe of potential users, different specialties, different settings?
Yes, absolutely.
And so, you tell me a little bit from your perspective as a clinician and from speaking with clinicians in the field. How is this received? How does this change the experience of an end user?
Well, interestingly, when people see what we do, I've heard it called the Holy Grail. I've heard it called how do I get this? It's the most marvelous thing I've ever seen. It's accepted very well. The problem with what we have today is a lot of the EHRs are baked in and they are not in innovation mode at all. So they continue to do what they've always done, which is collect information, silo that out within a record, and say, hello, provider, you get to decipher what's in here. Stuff's over here, over there, everywhere. That's the usability, one of the usability issues that we solve. So we have that ability to present to the provider exactly what they need at the point of care. In addition to that, all the things like quality measures and HCC calculations for Medicare Advantage, billing questions, all of that also has a look into the record to get what they need as data. So not only do we have a provider-facing workflow focus, we also have the ability to send that same workflow view to other people who need to look at the chart.
And that can happen presumably in real time or near real time to accomplish that end, right?
Absolutely.
So it sounds like that's an improvement both for clinician experience, but also in terms of care coordination.
Oh, absolutely. One of the silver linings, if you want to call it that, in the pandemic is that we have exposed the fact that we cannot transmit clear clinical information from place to place. It's interesting that the CDC put out a little blurb to all of its hospitals it's connected to say, please send us X, but they wanted it in a flat text file. So it got switched over. They can't do anything with it once they get it. So it switched over to HHS, and they're in the same boat as the CDC. So we really don't have in this country yet a good way of exchanging clinical information, both just for patient care, which is the most important thing, but also for research. So as we have found out, COVID, as we've gotten into this as a disease, has multiple different layers and multiple different symptoms and sequelae that we didn't know existed when it first started. Having that good flow of clinical information would have surfaced that, I believe, much more quickly.
Right, it makes sense. And I mean, as an old public health hand, I'm looking at this from a public health perspective as well. And the inability to transmit data in a useful fashion to CDC or HHS is really problematic. And I've heard, anecdotally about, healthcare institutions who basically had to have several, if not more than several, FTEs purely for the purpose of extracting information from their internal records and typing them in to the CDC or HHS portals.
That's really not the way to do it in my mind.
No, not really. Not really. So we're talking about EHRs, we're talking about AI, and I think what I hear you saying is that rather than trying to disrupt the installed base of EHRs, what you've created is a layer, sort of an application layer that integrates with the EHRs, that provides an additional level of usability and usefulness, providing relevant, actionable information. How does that play with the EHR ecosystem, with the clinicians? I mean, you said clinicians are fans, but how does it work with their institutions? What kind of adoption are you seeing?
Well, when institutions figure out that good clinical data is actually useful to them, the adoption is much easier. The issue with most of the EHRs today, like I said, they're kind of hard-baked. So they were developed for doing transactions, basically, They were not developed to help physicians do what they need to do. They're just left to figure it out, do it the way we've constructed it, see you later. So some EHRs have been very open to layering us on top. Some institutions are very open to layering us on top. The big names in the industry are a little slower, as you would expect, to adopt this. But how we've had several inquiries from their customers, though, regarding how do we layer this onto what we already have. Because the last thing anybody wants to do, I've said on several hospital boards, is rip and replace that infrastructure and try something new.
Right.
They would like to make it more useful. So that's kind of our mission in life. And that's the whole reason I got into healthcare IT was how can we make these systems work for the person that has to actually do the work?
Right. So I'll take a little side trip here and ask you, how did you get into health IT? Not many clinicians do, but certainly there are a lot of clinicians in health IT today.
Well, I was the president of a fairly large multi-specialty group practice in Illinois, and we installed our EHR back in 2000, which was at the very early stage. The functionality was just not there. So I have a minor in computer science, so I thought, no, we need to figure this out. And time rolled around, and this particular company was named Integrate, said, can you be our consultant for this? I said, okay. One thing led to another, and I got into first the EHR world. And of course, with acquisitions going on, I went from that to a semi-billing EHR company called Med 3000. So we got into the HCC Medicare Advantage billing side of this along with the patient care side for the providers. And then I just made the switch. So I practice doing telephone medicine on shifts when I have time. And basically, this is now my full-time job. So I've converted over to basically trying to get these systems to help providers and their organizations get their work done without being so stressful.
If you're just tuning in, this is Harlow on Healthcare, coming to you on Healthcare Now Radio. I'm David Harlow, and my guest today is Dr. Jay Anders, Chief Medical Officer of Medicomp Systems. Jay, at this point in time, as we're speaking, we're in the midst of this COVID-19 pandemic, and I'm wondering how this situation that we're living through plays a role in determining the importance of EHRs, the importance of the tools that you describe, and more broadly, the importance of the use of AI in healthcare.
Well, I think one of the problems right now with providers is basically twofold. One is they're dealing with a pandemic, meaning that every patient they see almost has the potential of a very serious communicable disease. And there's lack of PPE and the stress of all of that, either working in an urgent care center or an emergency room, or even in the operating room and doing surgery. It's very, very stressful now because of that extra risk involved with that. You couple that with the fact that if you're saddled with an EHR system that's very hard to use, or it's not giving you what you need, and people in the profession were burning out before the pandemic. So one of the biggest complaints of providers was these EHRs are not designed for us. They're designed for somebody else, but not us. So you take the fact that they're stressed at work, they're seeing a lot more patients trying to get through this, and then you still have the same old system. It's not a wonder that providers are starting to burn out and leave. So folks that have had the ability to exit the profession are starting to do so. And they're older physicians, actually some are younger physicians that have decided that there might be another path for me.
Well, that sort of burnout is concerning, of course, and I'm wondering how the technology solutions that you're working on can address burnout. Is that part of what's at stake here?
Well, it is. One of the reasons, like I said, I got into this side of medicine was to make that life a little better. Our whole goal is to have the provider practice the medicine they were trained to do and let everything else take care of itself. What I mean by that is give them clean documentation tool, so that you got to do a document anyway, but don't worry about all the other things that you worry about in healthcare right now. And that's quality measures, HCC calculations, the brand new 2021 billing that's about to come out January 1st, which is kind of an interesting thing. But let the docs practice. Let them do medicine. Don't make them run around corners to find the medicine, the information they need, or to practice that medicine. So our whole goal at Medicomp is to streamline the patient and doctor experience to assist them in doing what they do and allow their organizations to collect the data that they need to collect to make them a viable organization again.
So I'm wondering, do you see the latest round of interoperability rules that are not quite yet in effect as some panacea, or the next step on the road to some panacea solution for integration, for sharing of information, for cutting down on some of this stress that you're talking about?
Well, interesting you bring that up, because one of the biggest pushes of the new interoperability rules is to give patients access to their medical records. That's been one of the number one things you'll read about this. And what they've done is very, very little on setting standards of how information needs to be transmitted, and allow for the pipelines to be built to allow that to be transmitted. So there are folks out in our industry that says, we're already interoperable. I can send you a fax electronically and you can put it in your system. That's not the answer here. That medical information has got to be integrated with all the other medical information that's in a chart to really make it useful. So yes, I'm absolutely for patients having access to their medical records. That's extremely important because they need to be partners in their healthcare. But also, that relevant clinical information needs to be sent and incorporated into whatever system the provider is using to treat that patient. So they have current, correct information to act upon. So we'll minimize errors, we'll minimize duplications, and we'll provide better patient care.
So the standard for interoperability is based on FHIR. And over time, as I understand it, and I'm not a technical person, there are a number of different flavors of FHIR. And in trying to achieve interoperability, it seems to me that we need to standardize what we're talking about. In this current iteration, as far as you're aware, or as you've been working on any aspect of this, are we talking about a single version of FHIR yet, or are we still talking about different flavors?
As far as I know, currently, they're still talking about different flavors. And the interesting thing is that those flavors now sometimes have sprinkles. So I've got my chocolate cone, and let's change it up just a little bit. We'll add this to this particular section, or take that away, and we'll change that. Every time standards are changed, everybody that deals with those standards has to change. And until we settle and get together, that's going to be a problem, because I would rather have EHR companies and us look at innovating, making the experience better, the safety better, the quality better, than figuring out that this tiny piece of data that was coded XYZ is now PDQ.
So is there, it seems like there's a lot of effort gets expended on sort of cleaning data in ways that maybe we could, if we agreed on some standards, then that could be helpful. It brings to mind the classic cartoon, XKCD cartoon, right, with people complaining about multiple standards, and the solution is another standard.
Right, exactly.
But if we don't normalize to a single standard, then we still have that problem, or an even greater problem. Are there? I know it's sort of building like solutions to problems that we shouldn't have, but do we have in this day and age solutions to that problem that maybe we didn't have 5 or 10 years ago, to be able to translate across these different standards more easily?
Well, I think we do. The fact that they've said it's FHIR and not CDAs, CCDs, and all the other flavors of records, clinical data records that are available, that's a start. The other issue is there needs to be common language used, and that means common terms. And the reason I think we're pretty successful at what we do is the fact we had that, and we have constructed it to basically mimic how a clinician thinks about medicine. So it's more clinically relevant information that what we can take in, massage, and transmit back out than some of the other nomenclatures out there. So yes, there are things today, ours is one, that can be layered upon or stuck into existing systems that will make them markedly more usable, markedly better in patient safety and care, and much easier to be interoperable.
Great. So hopefully we get there a step at a time. Are there some specific changes that you see on the horizon, either from a policy perspective, from a standards perspective, or from the perspective of changes that individual institutions and providers could be making that would help with making the EHR and related tools work better and deliver care to patients better?
Well, I think it's going to be very interesting once we start to exit this pandemic. And what I mean by that is almost every medical institution, clinical entity, hospital that I'm in contact with or deal with have their heads down in this particular problem. So folks aren't very interested, and this is what's going to be interesting about the new interoperability standards. They're going to pop out January 1st. We haven't exited the pandemic yet. So hospitals and care institutions are focused on the care of those patients and how do we mitigate, migrate, navigate through all of this. Once that happens, I think we're going to have a look at what could we do better and what did we do wrong. And I think that's where you're going to see things like things that we do and others start to be looked at very carefully about, let's fix this problem so we don't have this again. So we don't spend 3, 4, 5 months not being able to gather information that we should have had within a couple of weeks. So that's what I think is going to happen down the road. But we're going to have to be clear of this first, clear of the COVID-19 pandemic first, before people really seriously start to look at, okay, we've had enough of this way because that didn't work. Let's find something else that does.
So looking a little further down the road, I'll ask you just to wrap up, if you were to wake up tomorrow and find yourself 5 years in the future, what's one thing in healthcare that you would hope or that you would expect to find has changed drastically?
Wow. Well, I would hope 2 things. I'll give you 2. I think that artificial intelligence, as it deals with medicine, needs to be an assistance to the clinician's knowledge, not a replacement of the clinician's knowledge. And I think we'll see that. We're going to see systems augment the clinician's knowledge much better than they do today in 5 years. In 5 years, I sincerely hope that regardless of where you walk into, there will be a way for you to collect all the information about a patient while they're there in front of you. So you have a complete clinical picture. I think it's going to happen, but I've said that now for 10 years. And it just keeps getting, the can gets to get kicked a couple of times. And if they keep kicking it, it's not going to be there in 5 years. But I think this pandemic has taught a lot of people a lot of lessons. And I'm hoping that some of those are silver linings as they pertain to electronic healthcare and the transmission of clinical data from place to place.
Well, that is an optimistic view and a silver linings view. And I hope that indeed comes to pass. Well, Jay, thank you very much for joining us today.
Thank you for having me. I appreciate it.
You have been listening to Harlow on Healthcare. Join us at healthcarenowradio.com. Let's continue the conversation on building the future of healthcare together at #HarlowOnHC. I'm David Harlow, keeping the fire going and holding a seat open for you. Until next time.